Another disease that we'll briefly talk about is the cause of excess endogenous insulin, an insulinoma. It is an exceedingly rare tumor of beta cells within the pancreas, which, as the name implies, secrete excess insulin. The excess amount of insulin causes glucose to enter cells and leads to states of hypoglycemia. In order to diagnose true hypoglycemia, one must fulfill 3 elements of the Whipple's triad. This includes hypoglycemic symptoms, documented low plasma glucose levels, and resolution of these symptoms after glucose injection. In order to diagnose insulinoma, one would need to measure insulin levels and C-peptide levels. C-peptide is important to rule out surreptitious insulin injection. When insulin is made endogenously, you will see increased C-peptide as a byproduct. If you give exogenous insulin, there won't be any extra C-peptide being created, so C-peptide won't be elevated. Finally, the obvious treatment for insulin-secreting tumors is to simply remove it through surgical methods. Alright, we're almost at the end of the pathology section. Let's finish strong by wrapping up with a discussion of 3 high-yield endocrine syndromes that are frequently tested on the USMLE Step 1. Before we discuss carcinoid syndrome, we need to understand the underlying cause, which is the carcinoid tumor. These are derived from neuroendocrine cells, which should automatically make you think that there may be some type of neurotransmitter-related hormone being produced, and you're absolutely right. These tumors produce serotonin, or 5-HT. Additionally, they produce kinins and histamine. Where are you most likely to find this type of tumor? Well, they are most commonly found near the appendix, but can be found anywhere in the small intestine. If they are most commonly found in the appendix, where do you think they metastasize to? Well, the liver. So since these tumors produce serotonin, they can have a wide range of effects on the body when serotonin enters the circulation. But the interesting thing is you won't see any of these effects if the primary site of the tumor is upstream of the liver. This is because the serotonin gets metabolized in the liver during first-pass metabolism. Therefore, you actually see symptoms of carcinoid tumor, called carcinoid syndrome, if it has metastasized to the liver or beyond. So remember this first-pass effect. So what makes up carcinoid syndrome? Well, you have diarrhea, skin flushing, and wheezing. And why does this occur? Well, the flushing and wheezing are due to histamine and kinins released from the tumor. In fact, skin flushing is the most common symptom. Diarrhea occurs because cells use up tryptophan to make serotonin. As a result, there is not enough tryptophan available to make niacin. And you get similar symptoms that we see with niacin deficiency, also known as pellagra. If you recall, the symptoms of pellagra are remembered using the mnemonic diarrhea, dermatitis, and dementia. The other really interesting finding you may see is right-sided heart valve fibrosis, which may present with a new murmur. Now you're probably asking yourself, why is the right side of the heart affected and not the left? Well, it turns out that the left side of the heart has monoamine reductase, which is an enzyme that can break down serotonin, while the right side does not. As a result, you only get fibrosis on the right side of the heart. So if your physical exam findings suggest that your patient has carcinoid tumor, then we go on to choosing the correct diagnostic test. In this case, we test the urine for a byproduct of serotonin breakdown, known as 5-HIAA, which stands for 5-hydroxyindoleacetic acid. The other interesting thing about these tumors is they express a high level of somatostatin receptors. That is why we can use the drug octreotide, which is a somatostatin analog, to help inhibit the secretion of these hormones. Additionally, a test we can use to identify the location of carcinoid tumor is the octreotide scan, where we radiolabel octreotide and visualize areas where it concentrates using scintigraphy, which basically is an imaging technique where we use cameras to detect radiation from these radioactive isotopes and create a 2D image. Treatment is either with resection, the somatostatin analog octreotide, in cases where the disease has already metastasized. Lastly, remember the rule of 1/3 for carcinoid tumors. 1/3 metastasize, 1/3 present with secondary malignancy, and 1/3 are multiple. Zollinger-Ellison syndrome occurs in the setting of a gastrin-secreting tumor, or gastrinoma. These are often found in the so-called gastrinoma triangle, shown below, which includes the pancreas and duodenum. Because there is hypersecretion of gastrin, we get an increased production of stomach acid, leading to recurrent distal duodenal and jejunal ulcers and thickening of the rugae of the stomach. In fact, if a patient presents with ulcers of the distal small bowel, this is virtually pathognomonic for ZE syndrome, as normally we don't have high enough levels of stomach acid to cause problems so far away from the stomach. Another effect of this disease is diarrhea and malabsorption. If you're not familiar with gastrin, don't worry. You will learn more about this and other digestive hormones in the gastrointestinal lectures. Lastly, there's an association of Zollinger-Ellison syndrome with MEN1 syndrome, which we'll discuss next. Okay, time for another flash quiz. This flash quiz is a patient who presents to you with facial flushing, diarrhea, and holosystolic murmur, best heard in the left lower sternal border. What is the diagnosis? I hope this wasn't too tricky. Let's first go over the murmur and see if it gives you a clue. So when you start with murmurs, I like to first pay attention to when it is occurring. Holosystolic means it will be occurring during the time between S1 and S2 and is constant. Now there are three main murmurs associated with this. That is a VSD, tricuspid regurgitation, and mitral regurgitation. Now which one would be best heard in the left lower sternal border? I hope you're saying tricuspid regurg. And if you are correct. If these murmurs are not familiar to you, I suggest that you look over the cardiology section. Remember, very rarely will the boards give you the murmur's name. Often they'll make you figure it out by listening to it or describing it in words. So here we have tricuspid regurg murmur, diarrhea, and facial flushing. Does that help you figure out what it is? If you're saying carcinoid syndrome, you're absolutely correct. Now the moment you've been waiting for. I've mentioned multiple endocrine neoplasia, or MEN, a number of times, so here's your chance to learn it. The way you'll be tested on this is not by regurgitating what you know about the different associations, but rather, you're going to be given a clinical scenario and will have to piece together the associated symptoms. So I'm going to teach you about each one of them, and we'll do a couple practice questions to see what you remember. The way I remember the MEN syndromes is using a mnemonic. First we have MEN1, which is associated with the 3 Ps. These Ps are parathyroid hyperplasia, pituitary tumors, and pancreatic endocrine tumors. Specifically, for pituitary tumors, we have the all-common prolactinoma, and the second one you might see is a GH, or growth hormone secreting tumor. Then, for the pancreatic endocrine tumors, you have gastrinoma, or Zollinger-Ellison syndrome, as the most common, but other types such as insulinomas, VIPomas, and glucagonomas can also exist. Of note, VIP is vasoactive intestinal peptide, which causes you also to have diarrhea. And glucagonomas are characterized by hyperglycemia and can have features of a red rash that is crusty, scaling, and painful, and often is found in the groin region but spreads to other areas of the body. This is called necrolytic migratory erythema. As it says in your text, these patients may present with kidney stones. Why do you think this is the case? Well, if you have parathyroid hyperplasia, or tumor secreting PTH, then you will get hypercalcemia, which increases your risk of stone formation. This is a hint to how you're going to be tested on this, so stay on your toes. Why do these patients have kidney stones? Well, because of hyperparathyroidism. Men 2A and 2B are grouped together because they have some common overlap. For example, both are associated with medullary thyroid carcinoma. Do you remember what gets produced in excess with the medullary thyroid carcinoma? Calcitonin. In addition to medullary thyroid carcinoma, MEN 2A, also known as Sippel syndrome, has 2 other associations that both start with a P. These are pheochromocytoma and parathyroid hyperplasia. The way you use the mnemonic as MPP for this one, as you can see, as we move from MEN1, MEN 2A, and from MEN 2A to M2B, we lose a P and gain an M for each step. Make note though, in MEN 2B you have 3 M's. So MEN 2B, as we mentioned, is also associated with medullary thyroid carcinoma of the thyroid, just like MEN 2A. And also like MEN 2A, it is associated with pheochromocytoma. So that takes care of the P and one of the M's in our mnemonic. But what about the other M's? One of them is mucosal neuromas. In addition, the other M is marfanoid body habitus. Mucosal neuromas or ganglioneuromas are going to be described as small nodules on the lips, and the term marfanoid body habitus will describe a patient who is tall, with long fingers, arms, and legs. So really quickly, you can review the mnemonic for MEN syndromes. We have MEN1, which is PPP. We have MEN2A, which is MPP, and MEN2B, which is MMMP. Lastly, you can see that I've added shapes drawn at the bottom to illustrate the relationship between the mnemonic and the location of these tumors, based on head-to-toe orientation. If this helps you remember it, by all means use it. The MEN syndromes are easily testable genetics questions. Remember that all of them are autosomal dominant in inheritance. However, MEN2A and 2B are specifically associated with a mutation in the RET proto-oncogene. Okay, time for a flash quiz. A 30-year-old woman complains of episodic anxiety attacks with concomitant sweating and headaches and describes a shooting pain from her back radiating down to her groin. Labs are notable for an increase in serum calcium. What diagnosis could explain her symptoms and lab findings? The answer is MEN2A. First, you need to realize that shooting pain from the back to the groin with hypercalcemia is a sign that this woman has kidney stones. Now, why would she have high calcium levels? Perhaps she's making too much PTH. Let's keep going. Now we hear a story of what sounds like a pheochromocytoma. Now you must be thinking, what does hypercalcemia and high PTH have to do with pheochromocytoma? Well, start thinking about some of your syndromes. In particular, let's focus on the multiple endocrine neoplasias. Is this ringing a bell? I hope so. You should be thinking MEN2A. Remember that it is also associated with medullary carcinoma of the thyroid. This is exactly how you're going to be tested on the MEN syndromes. Let's try another one. This time I'll give you some key words. Okay, test yourself. A 43-year-old man presents to the ED with a sudden onset of headache, sweating, and palpitations. He appears anxious, and his face is flushed. Blood pressure is 170/95. Results of a recent workup for hypertension done by his outpatient physician show elevated urine metanephrines on a 24-hour urine sample. Which of the following is the most appropriate initial pharmacologic agent for this patient's condition? A. Phenylzine, B. Phenoxybenzamine, C. Phentolamine, D. Phenylephrine, or E. Propanolol. The correct answer is B. This patient has the classic presentation of pheochromocytoma, which again is a tumor of the adrenal gland which promotes excess catecholamines. Patients complain of spells of impending doom with symptoms of headache, palpitations, diaphoresis, and anxiety. In addition, elevated blood pressure. The first-line treatment for this is a non-selective alpha blocker, such as phenoxybenzamine. Phentolamine is the only other alpha blocker listed, but due to its short duration of action, it is infrequently used. Alright, let's do another test yourself question. An 18-year-old woman is referred to a specialist for primary amenorrhea. She reports generalized weakness and bouts of nausea and vomiting. Her blood pressure is 160/99. Laboratory studies reveal a potassium level of 2.2. She is diagnosed with a condition that affects 2 of the 3 major adrenal hormones. In which area of the adrenal gland is this one functioning hormone produced? A. The capsule, B. The medulla, C. The zona fasciculata, D. The zona glomerulosa, or E. The zona reticularis. The answer to this question requires that you recognize that this is a case of congenital adrenal hyperplasia, specifically 17-alpha hydroxylase deficiency. If you recall, patients with this disease are unable to produce glucocorticoids or androgens. Thus, due to the shunting of precursors such as pregnenolone or progesterone through mineralocorticoid pathways, there is an excess of aldosterone production. This leads to both hypertension and hypokalemia that we see in this patient presented here. Note, low androgen production results in a phenotypic female with no sexual maturation. So the answer here is D, the zona glomerulosa. Before we end this section, I just want to say thank you for sticking around and challenging yourself with these questions. If you missed any of them, I highly encourage you to take a moment to make a flashcard, or whatever it is you like to do to help you remember these things, because you're going to get a question on these syndromes, and it is going to be pattern recognition of things that don't seem to fit together at first. But then you have to remind yourself to consider the men syndromes in your thought process. Now give yourself a quick break and come back to endocrine pharmacology.